This is why you're not fixing patients. You are failing your patients because of this one issue. What is the one issue that would fix all of your patients and you would never have to worry about it again? No. Okay, let me try again.
That sounds like that Cairo kid that he was like in Cairo school when he started. He's got like 300K followers now, but he was always so forceful like that.
What? He's on
Yeah.
YouTube or something?
He's got like 500,000 on Instagram already.
Do you think subluxations are the reason? I'm going to tell you how to fix all your subluxations now. Are adhesions getting in the way of your musculoskeletal system providing you with optimal life? Today, we give you the answer. Wait to the end, but before we do, click the like button and subscribe. But serious, which one do we do? How to fix all your patients. This is why you are not fixing your patients. That's what we want to go with. I think we just leave it all in and say, welcome to the Anatomy of Therapy. I'm Dr. John Cybulski. Today, we're here with Bobby Riley, and we're telling you all of the answers to all of your problems today. The main problem, though, is hyperbolic. When your doctors are hyperbolic, they're not giving you level-headed answers. You've got problems. We need simple speak. People only know what you tell them. That's a Leonardo DiCaprio line from Gangs of New York. You should watch that movie. Who's the other actor in it?
The Academy Award winner. He's three-time winner, I think.
Any movie that he's in, I'm watching 100%.
Yeah.
But people only know what you tell them. Patients only know what you tell them. Be careful what you tell them. I do think we're not going to go into the psychology of it today, but I do think I want to go into something I actually posted about the other day loosely. The post the other day was about postural endurance. And I don't think people kind of think about this element with posture specifically, but we're not going to talk about posture. It's dosage, it's endurance, it's strength. Like what really affects change. Sometimes a little, let's just say, snap and necks and cash and checks chiropractor will feel good for a second, but perhaps it doesn't fix the neck long term. Why is that? That's the real problem we're solving today. Welcome. Hey, Bobby, how you doing today, man? What do you think that is a problem as well, or am I just making this up?
Yeah, I mean, hyperbolic or false confidence. Yeah, that whole categorization is fair, I think. Yeah.
But how would you phrase the problem of, I would say, dosage? That alternative healthcare, PTs, chiropractors, physios, one of the main problems is dosage. We don't give enough dose, I think. How would you phrase that problem?
Yeah, I would say like everything you're doing is probably too passive. Everything the patient's doing, everything you're doing, almost everything is probably too passive. There's probably like 20 people in the world who have completely set up their systems to revolve completely be irrelevant to money because it's already successful, so they can just run their clinic exactly the way they want, and everything they do is just value driven towards their patient, like whatever they believe in, right? And like Stuart McGill, we've talked about this 3-hour new visit, right? Or first visit, stuff like that. There's a handful of people in the world that do this, but I think the Venn diagram, most of this bubble is going to be people who have to either they're incentivized by a monetary model to increase the patient flow or decrease the patient time with the patient, or to check off insurance boxes to make sure that they can get reimbursed for certain things. The models are, we know this with medical care. The average, I think in the States, the average is 7 minutes with your general practitioner. Right. You may get more time with a PT sometimes, but they may only pay for so much time, and then they're going to follow certain protocols sometimes, and then in some states they still have to wait for a doctor's note, and you know what I mean. Like the system is really not set up, as crazy as it sounds, to optimize care for people. I don't believe so anyway, and then when you're not optimizing care, you're optimizing And it's to be fair, like you have to like pay your student loans, you have to pay for your house, you have to feed your family. Like,
Right.
I don't blame anybody for the way that, that they've fallen into a way of treatment. But I think, so many of these models are based off of this idea that it has to be that's what I said, like a business model. It has to be viable
Yeah.
to work. And then that's where a lot of times you're being too passive comes into play, right? Because
Right.
you won't take the time to show the exercises because it takes too long, or you'll just maybe give them something super simple because you have 1 minute left. You say, hey, here's a printout. You give the same printout for glute med for everybody who has hip pain or
Right.
back pain, and yeah, you're giving some value, but it's really not probably the answer, except for every 15th person who comes in, that's exactly what they needed, maybe.
Right.
But this is yeah, I think this is the main problem that I would like to expound upon.
Do you think, I agree, do you to an extent, do you think within the system, like I feel like doctors get into the system and they have an idea of how to treat patients, and then they realize if they treat in the way that they initially feel like they should treat, that won't get reimbursed, right? And then they realize that, and so the system then kind of starts to dictate. Fucking cat, jeez. Cat comes and knocks over water. Okay. Yeah, I got a hyper black cat in this house. It's a problem. Hold on 1 second. Jesus. We're gonna hit pause. Well, let's just keep going. It's gonna get wet. It's fine. Life happens when you record podcasts, guys. This is real. This is life, and this is what's happening. Then you think people conform to the system, basically, right? So like not necessarily in consciously, maybe even, where they're like, okay, I don't think doctors are out there going, I'm going to give my patients less than the best care. I can't wait to go and provide mediocrity today. Like, I really don't think any doctor goes to work saying that in the front of their mind. I think out of habits, well, that's not good. It's water everywhere. That they have to kind of conform to these systems to be efficient, and that it just kind of slowly seeps into their practice. Does that make sense? Like, I don't think you believe that doctors go in going, can't wait to make, well, maybe some doctors do, can't wait to go in and make a bunch of money. They for sure say that, but they don't go, I can't wait to deprive people of what they should get. You're not saying that, right?
No. I mean, I don't think any general practitioner wanted to, only just nonchalantly prescribe medication to every person, or every chiropractor wanted to do as short a visit as possible to drive as many, Porsches as possible. But
definitely Porsches.
But no, it's more like, yeah, like I think we should break down what I'm, what I mean by you're being too passive, right? Because
yeah, let's.
I don't. It's not like everybody's too passive at all aspects, right? Somebody might be too passive at active care, and another person might be.
Okay, let's stop there. What passive with active care? Let's start there. What is something that's too passive with active care you wish was not? Like, what do you see as people that are too passive with active care? Let's give an example.
Well, man, in the chiropractic field, that's really easy because some of them, there is no active care, period. I mean, everything.
That's very true, yeah.
Everything is passive care, right? So, I mean, when I was a CA, a chiropractic assistant, when I was in school, my job was to take the patient back, put them on like UV light, and then put them on laser, and then put them on a swivel ball, and then put them on E-stem. I did like, I don't know, 7 modalities before the chiro came in and adjusted them in like 30 seconds and then left, and they billed all that. So as the CA, my job was just to like run them through a bunch of passive stuff that like there's little to no cellular response to that care, right?
Sure.
So there's just zero active care. Like, they might throw in some AK balance thing at the end, but that's not true acquisition of change in the body, right? So,
Right.
I mean, in the chiropractic field, it's really easy to say or to show examples
True.
of being too passive with active care. You know, in
For
PT,
sure.
less so, of course, because that's kind of their game. But they could be maybe passive in other areas. But it's not really my, you know, I'm not a PT. I didn't go to PT school. I don't, you know,
Yeah.
I'm not here to say anything about them. But I mean, the active care one is, yeah, very,
Well,
very easy to
look,
understand.
for sure.
And I think even with the people that give active care, I think they probably underestimate the they're like when you give somebody one set of 10 or a 30-second stretch, like here's
Mm,
6 different stretches that you're going to hold for 30 seconds or 20 seconds. I see this stuff all the time. You're just going to hold your knee to your butt for 20 seconds, then you're going to
right.
touch your toes for 20 seconds,
Yeah.
then you're going to do this groin stretch for 20 seconds, and you're going to do this like 3 days a week. That's the same mentality as like the female who says, I don't want to bodybuild because I don't want to lift weights because I don't want to look like Arnold Schwarzenegger.
Right.
It's like
Right.
you're never, ever,
Don't
ever
worry.
going to look anything like that. You know what I mean? So
Don't worry.
the amount of stimulus, or, you know, I used to
Right.
work at GNC when I was in college, and I'd have
Yeah.
these young kids come in and say, I can't gain any weight. And they want me to, and of course, I was a terrible GNC salesman because instead of saying, here's the latest muscle tech supplement, buy like
Right.
10 of them,
Yeah.
I said, what are you eating? And they would give me this list of like, you know, 1900 calories that they were eating every day. And I was like, you're
Double it.
19 years old. You
Triple it.
play football for 3 hours a day.
Right.
You need to
Right.
be eating like peanut butter and jelly sandwiches like every 90 minutes all day
Right.
long, and protein and steak and whatever you can jam in your face.
Right.
And then you can come back and I'll sell you creatine uh, to help with something.
Worst
You
employee.
know what I mean? And
Yeah.
that's so this expectation that our body adapts to this extremely subpar stimulus
Mhm.
is, I think, rampant as far as clinical care goes.
Is this okay? Let me take it a step back. I love it. I totally agree. Do you think this also could stem from the position, especially in the therapeutics setting, that when people are in pain, they feel very fragile? Now, I know
Mhm.
we're supposed to say everything is we're supposed to go for anti-fragility and resiliency. Um, you're tough, your body can do more. I know that. I've heard these arguments. When patients are in pain, they feel very fragile.
Mm.
And when they are conveying their pain or their situation, their history, all of this, or even their experience of tests, or even their experience of, I should say, exercises, they're like, okay, it's a second visit. The PT gave me hamstring stretches and quad stretches. I pull my heel to my butt for 60 seconds, and I did that every day this week. And afterwards, my knee was like, I don't know, I think it was popping more. I don't know, and it feels inflamed. I think I'm more inflamed. So they, f- there is this, theologically speaking, a spirit of fragility in the therapeutic setting, and it's hard to break. It's hard to get people out of that mindset. And so I guess I'm answering my own question. I think doctors are picking up on that fragility, that people are in pain,
Mm.
and trying to weave their way around within that system. And I do think the monetary system is 100% a thing as well. But I think patients bring this fragility in. Is that
Yeah,
fair?
no, that's super fair. And you know, that makes me think that, you know, clinicians, your job is also to kind of be like a coach. And, you know,
Yeah.
I like when people ask me, you know, is CrossFit okay? Should I do CrossFit? And I say, just as long as the coach is good, sure.
Right.
Because a good coach will know how to regress and lateralize every single
Absolutely.
movement you need. So, like, I mean, I have 25-year-olds that are like, I don't want to go to CrossFit because I don't want to tear up my shoulder.
Right.
And I'm like, there's like 85-year-olds in there doing CrossFit. Like,
There's a
if
master's
if
division.
you
Yeah.
if you have a good coach, it's no
Mhm.
problem. So that's the job of the clinician to say, okay, I understand. Like this single leg step down is painful for your knee. Let's do this instead. Or let me apply manual therapy to desensitize the tissue, and then we're going to resume loading, right?
Mhm.
So, but again, so yeah, that is a good example of where it's not always the clinician's fault, where passivity comes into play because we respond to the patient in front of us, right? And
Yeah, that's a
sometimes
good way to put it. That's a good way
we
to put
let the patient dictate the care
it.
because we don't want to almost like somewhat offend them in a way, you know? Yeah.
No, that's huge. One of my Dr. Offenberger on here is one of those doctors who so you sent me a post, Mark Bell post. Do you remember that one about your elbow tendonitis?
Yeah.
We don't want to receive an explicit rating, but he was basically like, F your elbow inflammation, lift heavy things, pick heavy things up and put them down. Like, and that's a little bit easier in his world, in the training world, where people are like, my knees are inflamed. Is there a good squat variation I can do for it? Mark Bell was like, F your squat variation, pick up heavy stuff, put it back down, get in the gym, eat clean food, eat, macro clean food and do it again. But I think one of the reasons our buddy Dr. Offenberger is so successful is he doesn't, I don't want to say he doesn't care, but he's just going to tell you what he's going to tell you. He's very straightforward in that sense. And I do think a lot of, and I'm guilty of this, is kind of people pleasing. When I pick up on that fragility, I want to go, okay, now I know you're back at, every time you just like take a deep breath in or you look to the left and blink twice, I know it's a sharp pain in your SI and it, you know what, but it's not true. You pick up on that and you're like, okay, we have to deal with that system. So I do think the idea of the system monetarily bends us into kind of submission in terms of what we code and what we do and our time with patients. But then also we need to be aware that the patients are doing this not intentionally, right? Patients aren't trying to manipulate you. But I do think that bleeds into people's active care, at least one.
Well, sometimes they do try to manipulate you. Actually, they want something, and if you don't give it to them, they're almost,
very good point.
They're pissed off. And I think early in my career, I was closer to you, but now, and almost to actually not almost, certainly to my detriment, I am quite straightforward with people now. So like they say,
I appreciate that.
My shoulder hurts since I've started to do Olympic lifting, and I was like, how long you been lifting? 2 weeks. Okay. What did you do before that? Well, nothing. I just worked at the office for the last 20 years. And I'm like, and you're surprised your shoulder hurt? Like, this is, I'm maybe not quite so mean, but I'm quite in their face. And also, I mean, I've had patients that come in and say, because, I have DC after my name, and I'll treat them for tennis elbow. And at the end, they say, hey, can you crack my neck? My answer is no. You know what I mean? Like my answer is, what does that have anything to do with the thing that you came in for? Right. And I haven't evaluated your neck. I don't know anything about your neck. Yeah. I haven't asked any history about your neck, unless it was related to the elbow pain.
Right.
And before I probably would have been like, oh yeah, sure. Come over here. Just take a seat. I'll adjust your neck, And now I think, and I've had this with patients where they're like telling me what to do. And if I refuse, like I never see them again. Yeah. And then if you do what you say, you might have this, what they say, you might have this patient now that you keep. And it's a little tricky line. And I think,
very tricky line.
I don't always placate the patient. And, but I think honestly, you shouldn't always.
No, so. I fully agree. And this is one of the things actually we were talking about, like, what is the big problem? You asked a good question. That our great friend Peter came up with, but like a great question, our buddy Peter, but like
great friend, real close friend,
dear buddy. We were just texting the other day, but like, what do we think is a problem that we uniquely see as a problem? That is kind of one of the variations of it, but one of the problems
that other people in your field disagree with you on. That's the question.
Right. And one of the things it makes you think about is what it triggers in my brain is, okay, how am I different than other people? What might other people, that's where my brain initially goes. What do other people think is a problem? How do I not think that is actually a problem? That's kind of the line of logic that my brain goes to answer that question. And I think about what other people think as a problem. And I think it is, especially because when you lose a patient, you go, what did I do wrong? They cancel the follow-up. They cancel all their follow-ups. You see 3 cancellations pop up on your email and you're like, ooh, that doesn't feel good. What did I do wrong? Where, and it's a natural human psychological reaction for someone to like kind of take something away from you. You know, you thought you did a good job and they leave. And so you go, okay, I need to, and especially when that happens, the next patient that comes in, you're like, oh, shoot, I got to make up for that. Well, now maybe I become more of a people pleaser. Like if this person wants me to crack their neck, even if they have tennis elbow, you know, I just lost 3 visits next week. Maybe I'll do it. I'm like, oh, okay, yeah, sure. I could see. Absolutely. It's all connected. Absolutely. And I'm placating doctors who give into these things, but I can see how over the course of years, it wheels yourself, it bleeds into your system so that you're always people pleasing. You're always trying to do whatever the patient wants. And then once you've done that, then those patients go out and go, man, I feel great. Bobby popped my neck. He ART'd my, you know, he did all these things that made me feel better. He gave me exactly what I wanted. And that'll get you some patients. Like you'll get some referrals there. And then every 6th patient goes, I'm not getting better. This is the next part. You gave me all the things that I wanted. Why is my shoulder not better? I've been Olympic lifting for 2 weeks and you've been putting hydrocolators on my back and UV light on my AC joint. And I've been doing the I's, Y's, and T's, but it is week 3 of my Olympic lifting and my shoulder still hurts when I go up overhead. Now, where are we at?
So everything is still in the you're too passive bubble. So you were too passive on creating expectations for the patient, right?
Sure.
So you didn't create any, you were light
Yeah.
on it. So now they're just wondering like, why has it been 2 weeks now? And I've done these I's, Y's, and T's for 2 weeks. You didn't set up any idea of like what they should expect from training, or that strength takes a minimum of 4 weeks, or at least growth. You know what I mean? Like you didn't prepare the person for that. So that's another category of passivity. And just real quick, I just wanted to clarify that when I'm saying you're too passive, you're not maybe being, you know, we all are guilty of not maximally helping the people in front of us. I'm not. In our last podcast, I clarified support for traditional chiropractic. So my point isn't to say every traditional chiropractor that's doing 3-minute visits is wrong. My point, this is directed at those who want to just fix people. Like they're kind of the nerds that are like, I want to figure out why this person has shin splints and how it's connected to their big toe. And you know what I mean? Like the person that's just really like, they're the Sherlock Holmes of our field. Like they just, that's what they really love about our job, is like to solve the case, not to just provide, you know, family care or adjustment relief or manual therapy relief, but you know, so this is what this is directed towards.
Yeah.
So I'm saying this is to the person who's listening and going, yeah, John said in that podcast that every 6th person that doesn't feel better. I'm thinking every 2nd person in my clinic that doesn't get better. And how the hell is he getting 1 out of 6, by the way? And I'm concerned about every other one that I'm having trouble with. That's the person I'm talking to. And I'm saying most likely it's a passivity issue. And you can think about it from as many perspectives as you want. I'm not saying you don't give great or good enough active care, but you might be too passive in your expectation approach. You might be too passive in connecting to the patient. You might be too passive in your history. You might be too passive in scheduling and planning. You might be too passive in your amount of time you spend with the patient. You might be too passive, you know, on and on and on and on.
I agree.
But I think the most straightforward one to understand is active care, because you're just saying, okay, the 19-year-old that wants to build muscle to make his high school football team, 16-year-old that wants to make his high school football team, and he's eating 1,900 calories and he goes to the gym for like 15 minutes, he's too passive. And everybody can understand this example.
For sure.
You have got to up your game. Everybody knows it's hard to hang on to muscle. It's hard. You have to work towards that stuff. Or if you want to cut. And why would we expect rehab to be different than like trying to look like Arnold, for example? They're very difficult processes. So you have to create enough stimulus for change. So this is the easiest one to understand. And I didn't plan to break down all the passivities, but
that's good.
I just want, and maybe that's not my job because I don't know them all and I don't know the listeners, but that's for them to go, hey, where am I being too passive in my maybe I'm too passive. Like while they're on the table, I'm not saying anything to them. I'm thinking about my day and when I can have lunch, and just think about how you're being passive in any aspect of your care.
I love it, man. Dose it. Let's when you asked me this question, like, what do I think is one of the biggest problems? I said dosage. That's just the word I use. It's the same idea. Dosage is either too low, because if you're giving an intervention with somebody, eyes, Y's, and T's, or external rotation with a TheraBand is a dose of some level. And I do think, since we are in the medical setting, that kind of makes sense. For me, and maybe this is just the way my brain is wired, when something good happens, and this could bleed over very quickly into a problem, I go, let's do more of that. And so lately I've been giving patients, in my mind, when patients come in, let's just say these last 2 months, maybe give or take, I go, what's the one exercise? What's the one stretch? Like, what's the one rehabilitative intervention that if I could only give this person one exercise, and I give them 2 or 3, but like, it really hones my mind into being like, yo, dude, do this every day. Do this one thing, do this every day. And these 2 things around it will kind of support this one thing. But drive this one home. And if I've done enough, it changes the way I question my history. It changes my evaluation. It changes what I say while I'm working on the patient. It changes how I set my expectations. And I go, until you can do this one thing, this will not happen. Now, if you do it 2 or 3 days a week, it'll be about 3 weeks. If you can do 10 of these, let's just, I'm making a thing up now. I'm saying Bulgarian split squats. If you can balance and do a Bulgarian split squat, if you can do 5 and not feel wobbly, and really feel your quad on one side and your hamstring on the other, and posterior hip capsule when you dive down to the bottom half of it, then you will notice, then you will know you have a change. Like, when you can hit 10 of these, no problem. And so I set a pretty hardcore expectation and a pretty obvious dosage with these exercises. That are part of them will also be a part of my test. And then when they do it, they'll be like, oh, I could get better at that. That's where I'm talking about dosage lately. But even if let's just say this, even if you're not thinking about exercise on perhaps that level, if I's, Y's, and T's do help the patient at 3 sets of 10 once a day, and they get relief for a couple hours, but then they go sit down, they need to be doing 30 rather than 10. They need to be doing 50 rather than 10. Do you know what I mean? Even if you're not thinking about these blow up the balloon exercise, external rotation on one side, lateral compression of the rib on the other, and they've got 2 tongue depressors on their left molars, you don't have to do that. If you find something that works, hammer that thing home. That's my one dose. Like, if it helps, I don't know, I hope it helps somebody figure out dosage. You kind of have to focus. You kind of have to think about what really works. Like, we were also having this conversation earlier. Bobby asked me, what do you think is the best hip flexor intervention? How did you phrase it? Is it an HEG split squat or a wall stretch? And then, of course, I wanted to complicate things, and I said it depends on the patient. But I think the ATG split squat is probably a more effective thing long-term for a majority of people than perhaps a wall squat or like a modified Thomas test stretch off the bed, for a number of reasons. But you have to almost condition your mind to like give these kind of, put your foot down and make a stand on what is it is going to be for that patient.
Yeah, and like what you just talked about is making me say, well, there's, for the clinicians who are listening who say, man, I'm not too passive on active care, I just hammer people with it. Then maybe what you're missing is you're too passive on connecting to what the patient will work with you on. So like I said, you're too passive on communication, you're too passive on connection, you're too passive on inquiry with the patient. So like, for some patients, you know who they are, the one that, runs ultras, the AskTIVs of the world are going to say, just this one exercise, like, that's it, dude. Like, they're going to say, give me like 9 more things I can do all day long.
For sure.
So, but besides those people, there's the other ones where they actually do need 6 things, and they need them every day, but they're only going to do one, and they're only going to do one every other day. Right. In that case, like, only with your due diligence in the history and figuring out the person who's sitting in front of you, will you know to say, hey, no, I'm just going to find the one thing that'll make the biggest impact for this patient. But I mean, just on this is a total side of, but I just wanted, I had, because I had a chiropractor who sent me a patient this week or last week, and she also came and shadowed and watched when I was working with her patient. And I think I surprised you with this like a couple of years ago, and we talked about it. But we were talking about hip mobilizations, kind of, on the table, leg over the shoulder mobs. And she was like, so do you do mobs to like maybe help the posterior capsule? And I was like, yeah, oh yeah. And she said like, you just do like 1 or 2. And I was like 50 or 60 or 70. And she was like,
a good episode.
She was like, what? And I was like, yeah, I don't honestly think there's a whole lot I'm doing to that capsule with one hard pull. And I'm like, and I told her, I go, I'm a big guy. I pull on that thing as hard as I possibly can for all 50 repetitions. And I'm like sweating at the end of it. Yeah. And that, like, that's just now, who cares if I'm right or wrong about how to do those mobilizations? The point is that's a total just perspective shift where I could just watch her brain go, well, maybe I shouldn't be doing 2, or 1, which is what I learned in school. Like this, let me check this out. Let me try doing 20 of them, or let me try doing 50 of them and see what happens. And that's, again, that somebody has to wake you up to that idea. Like I saw that in my internship, not in my school. And I just saw this dude cranking on joints like over and over and over again. And I was like, yeah, that kind of makes sense. And like, these people feel really good afterwards. And then he would redemonstrate, IR improvements, and he would retest and see these great changes. And then that got people jacked. And from there on, that just made sense to me. But that has to be, these perspective shifts have to like come to you somehow. And I don't know, that's the whole idea of, I don't know, just keep taking courses, keep having your attention open to new things, because without any attention shift towards any new perturbations in life, you don't really expose yourself to any kind of change. And there's just no way that we're even close to knowing what we're supposed to be doing every day. So like, almost in a way, we should be trying to find these what do you call them? Like these things that will shake up what we think every day, in the clinic or not. So instead of, waiting for the clinician in your team meeting to get done speaking so you can get your input, you can genuinely listen and go, okay, yeah, I mean, I've been doing this longer than this guy, but let me see what he's saying. Like, maybe I just didn't think about it from that perspective. And that you might not even copy them, but you might just get a whole new light bulb moment where you go, oh, I could try this though. You know what I mean? So, and this, I mean, John's talked about listening and stuff many times on this podcast, or delaying knowledge. What did you say?
Forego the restraint of speculation, or restraint of speculation. Yeah.
Delayed understanding. Right?
There it is.
Yeah.
I don't even know what I'm saying, dude. I think this is a great place to stop. I feel like we could also continue going on this for hours, but yeah, I would say, what are those areas where you are lacking in dose? Right?
The water is seeping into your motherboard.
Yeah, I know. It's like frying. There's little sparks coming up. No, my cat is thirsty. He's looking it up. Anyways, find those areas where you need more dosage. Obviously, it's this podcast. Obviously, it's liking this podcast. The dosage of you sharing this podcast is low. I will tell you that right now. You haven't told enough people about this podcast. Yes or yes? Too passive. Thank y'all for listening to the Anatomy of Therapy. We'll see y'all next week.
Peace. See you guys.